This video is about inpatient transfers, how to do them and what patients to properly use them on. My name is Nick Conti. I'm an athletic trainer, currently a student doing an internship in an inpatient facility. If you liked this video, check out nextwavept.com for more informational pieces like this one. Here's the log roll for supine to sit. Patient bends their knees to 90 and rolls over by dropping their knees to the side and reaching with their top arm. Make sure that the shoulder and the hips come all the way over. That will aid. Top arm pushes off the mat. Legs are dropped simultaneously with this push from that top arm, and then the bottom arm can assist as you get higher up. This is a good supine to sit for any patient because it takes strain off the back, but especially for patients with back precautions or back issues in general. Again, make sure that you help with the legs and upper body as needed. If you're helping just with the legs, I'd consider it a min transfer. If you're helping with the upper body and the legs, probably a mod or even a max transfer. For patients with hip precautions, a patient needs to sit up on their elbows slightly and move each leg at a time, being careful not to go into that internal rotation adduction with the affected hip, in this case the right hip. Moving over with the arms and legs in a stepwise fashion. Patient wants to stand up, they can scoot to the front. They should push off the bed or table with the opposite hand of the affected leg so that they lean onto that side. When they lean forward then onto that side, they'll flex more on that side as opposed to the other side so we don't break the hip precaution. This is the max stand pivot transfer. Patient is max dependent and won't be able to take a step. So we need to place the feet in a position where they'll clear each other when we pivot over because the patient won't step. The left foot is going to be in front of the right. The right's going to need to come around and not get caught up on the front foot, so it's behind the other one. The left foot is our pivot foot and is slightly internally rotated because as you see when we come up here, it's going to want to rotate. See it get caught there? So the more internally rotated, the better, letting it come around as you bring the patient around. The forward lean by the patient is very important in this transfer, so you may need to rock them a little bit to get them to start coming forward, especially if they have a fear of falling. My left leg is going to be the leg I use to pivot on for myself, and it's also going to block the right knee of the patient, assuming that's their weak knee. We're going to transfer towards the strong side, and my left knee will keep that right knee from buckling. The stand pivot transfer is for a less dependent patient, more like a mod. The patient actually is going to stand so the feet are right underneath them, lean forward, up, and take this step to get over. Make sure the patient is able to take the step or else you're going to have to sit right back down. For the dependent pivot transfer, the patient is positioned just like the stand pivot but without the step. The left foot forward, left foot internally rotated, right foot a little bit back. The patient is really going to need to lean forward for this one a lot. So there's a couple different handholds as shown there that you can do. Get the patient really far forward. The outside foot will be placed in between the legs of the patient so that you can open up towards the chair, not twist on your back. Getting the patient far forward, you can count 1, 2, 3, and go. It's all about using momentum and going quickly over. Make sure you take off the armrest of the wheelchair so that the patient's rear end doesn't hit it. The goal is always to get the patient to be independent. The independent pivot transfer is done with the same leg positioning as the stand pivot, with the front left leg internally rotated out in front of the back leg, assuming that the back leg is the weaker leg. That left foot is the pivot point. They're going to push all their weight through that leg. Left arm reaches across, so all the weight is on the left front leg and the left arm, and the rear end follows. A couple tips for this one is to get the rear end as close to the chair as possible and even angled slightly away from the chair so that the rear end has the least amount of distance to go. The chair is angled slightly towards the patient so that the rear end doesn't hit the rail as they come around. If the patient is having trouble with this due to coordination or weakness, one way to look into training them how to do it is to practice the head-hips relationship scoot. The idea of this is the head and the hips go in opposite directions. So by bowing the head down towards the opposite direction, the rear end follows. Practice this on a mat before you try to transfer into the chair. A lot of patients tend to do what's shown here is the head and the hips trying to go in the opposite direction, but the weight is on that front side and the hips are left behind. See this a lot and it's counterproductive. So when you want to do it into the chair, you set up in the same way as before, ready to go with that front leg forward, and that's your pivot point. Arms out in front And again, the body follows the hand there, but this time we're going to really emphasize the head going in the opposite direction so that the rear end goes right into the chair. Scooting forward can be difficult for some patients. Getting them to lean really far onto one side can be helpful. Here's one way to do it, really getting them to lean and pulling the hip over. And one way that works really well is to reach all the way over, getting them to lean really far and advancing that hip. For a patient with hip precautions and a back injury, we're still going to need to use the log roll so we don't harm the back. But if we use a pillow in between the legs, then we can avoid that adduction, possibly internal rotation as best as possible. So patient rolls over as we talked about before, readjust the pillow, make sure that knee is in line with the body, and then we drop down, really paying attention to that affected side. Working with someone after stroke with hemiparesis to transfer to the strong side is just like the pivot transfer or the stand pivot transfer, depending on the patient. But if you're transferring over to the weak side, it's a little bit difficult. We might have to do that if we're in a bathroom where you can only transfer in and out of one side, or in the situation where a bed is maybe in a corner. This can be potentially slightly dangerous, so make sure that they're a master before you clear them to be able to do this on their own without someone guarding them. So the patient is going to get as close to the chair as possible. The left weak side is going to be straight out in front because we're assuming that it can't do much and we don't want it to get in the way. The right side, the strong side, is going to do all the work. We need to get right underneath the patient, slightly externally rotated for it to be able to clear, but remind the patient that all the power is coming from that right arm and right leg. The patient's going to stand up, slowly sliding the right hand over the bed till their rear end is over the chair, and let themselves down slowly. So I hope this video was helpful. I'm Nick Conti. Come on over to nextwavept.com and get involved in the site. We're trying to post as much educational information as we can, but we also want to post some things that are submitted and get the conversation going. So come on over and be active in the site. A quick thank you to George, my clinical instructor, who helped me put this together. Thanks, George.